Imagine a surgeon uh, pushing a needle into a patient's neck, and then while the metal is literally still buried deep inside the tissue, they intentionally snap the hub to bend the needle 30 degrees.
Right, just to reach around a biological corner.
Yeah, it sounds like, I don't know, something out of a horror movie or maybe a desperate improvisation. But it is actually a highly calculated routine maneuver.
It really is. And I mean, for most of us, getting a medical injection feels like this totally one-dimensional action. You
Well,
know?
absolutely. You roll up your sleeve, you look away, there's a pinch, and it's over. We just think of it as pointing a needle and pushing a plunger.
Exactly. The common perception is essentially just delivering liquid through a tiny straw into a static sponge. It seems entirely uncomplicated, but the human body is, well, it's anything but a static sponge.
Which is exactly why we are looking at this stack of sources today. Welcome to today's deep dive, everyone. We are pulling from surgical technique manuals, gastroenterology journals, and biomechanical studies to explore the literal geometry of the human body.
It's a fascinating topic.
It really is. We're going to unpack how doctors navigate a three-dimensional microscopic landscape using, precise degrees and angles, and how our own cells, physically and chemically, fight back against that intrusion. Okay, let's unpack this. How do we even begin to map out something as complex as human tissue for a simple injection?
Well, to really understand the navigation of this hidden landscape, we have to look at what medical texts refer to as the special datas of injections.
Special datals.
Yeah, these are essentially the three fundamental geometric pillars of local and superficial mucosal anesthesia. So pillar number one is the insertion point.
Okay.
In clinical terms, a doctor isn't just looking for a general spot on the skin. The insertion point is defined exactly by the crossing of two specific anatomical lines.
Like finding coordinates on a map.
Exactly. Then pillar number two is the direction, which requires establishing a specific plane and calculating the exact angle within that plane. And finally, pillar number three is depth, which is measured down to the millimeter.
Wow. It sounds a lot like navigating a submarine through a trench or something. A pilot doesn't just go down or turn left. They need an X, a Y, and a Z axis.
Right, they need pitch and yaw.
Exactly. And exact distances to avoid hitting the ocean floor. But in this case, the entire coordinate system is happening in a space thinner than a dime right beneath our skin.
What's really fascinating here is why this absolute precision matters. The body is constructed sort of like a densely packed milfo pastry.
Oh, I like that analogy. Lots of flaky layers.
Right, you have completely different functional layers stacked right on top of each other. You've got the epidermis, the dermis, the subcutaneous tissue, muscle tissue, blood vessels, and nerves.
So there's barely any room for error.
There's basically none. If your angle is off by just a few degrees, or your depth is off by a single millimeter, you aren't just missing the target. You could be, depositing caustic medication directly into a nerve bundle.
Ow.
Or injecting a numbing agent into a blood vessel where it just gets swept away instantly,
Yep.
which leads to a complete clinical failure.
So it's a high-stakes geometry test. Where does this get put into practice the most? I mean, where is it the most critical?
Well, one of the most demanding environments to see this geometric strictness in action is the gastrointestinal tract.
Oh, okay.
We're talking about procedures like endoscopic submucosal dissection, or ESD, and endoscopic mucosal resection, EMR.
Right. These are the techniques used to remove early cancers and large, dangerous polyps from the lining of the stomach and the colon, right?
Exactly.
Basically doing surgery from the inside out. They use an endoscope, which is that long, flexible tube with a camera and tools on the end, and they snake it all the way into the gut. But looking at the manual we have here, they can't just slice the cancer right off the wall of the colon.
Oh, they absolutely cannot. I mean, the inner lining of the GI tract, the mucosa, is incredibly thin. And sitting immediately beneath that paper-thin lining is the deep muscle layer of the organ.
Which you really don't want to cut.
No, you really don't. If a surgeon takes a scalpel and cuts even slightly too deep, they slice right into that muscle layer, risking a full perforation of the colon or the stomach wall.
And that turns a routine preventative procedure into a massive, life-threatening emergency, right? Leaking intestinal contents into the abdominal cavity.
Exactly, which means they have to find a way to separate the thin, cancerous lining from that dangerous muscle layer before they make a single cut.
And they do that with fluid.
Yes. They achieve this separation by engineering a temporary artificial organ inside the patient. They inject fluid underneath the lesion to lift it up, creating what is called a submucosal cushion.
So the fluid itself acts as a physical barrier.
Right, it protects the muscle layer from the surgical tools.
This is where those specialized fluids come in. The literature lists hypertonic glucose, glycerol, and high molecular sodium hyaluronic acid. But why not just use standard saline water?
Well, standard saline is absorbed by the body's tissues far too quickly. It would be like trying to build a sandcastle with dry sand.
Oh, the cushion would just collapse before the surgeon could finish cutting out the tumor.
Precisely. High molecular sodium hyaluronic acid, on the other hand, physically acts like biological scaffolding. It's thick, it's viscous, and it holds the tissue up, maintaining that protective cushion for a much longer period.
Okay, but getting that fluid into the exact right layer is where the geometry becomes non-negotiable, right? The sources mention a very specific angle of attack for the needle here. So what injection angle relative to the mucosal surface ensures proper placement within the lamina propria, like 15 degrees versus 45 degrees?
That is the crucial question. If you want to ensure proper placement specifically within the superficial lamina propria, you would use a shallow 15-degree angle relative to the mucosal surface.
Because it just skims under the top cells.
Exactly. A 15-degree angle targets the delicate layer immediately under the surface cells, which is the lamina propria. But, and this is a big but, in the gastrointestinal tract, doing that is a disaster.
Right, why?
Because the lamina propria just isn't robust enough to hold a large volume of liquid. If you inject there, the fluid simply leaks out. It takes the path of least resistance and leaks straight back into the open cavity of the colon.
Oh, I see. The literature calls that intraluminal extravasation, right?
Yes, exactly. You get zero lift, and the tumor remains dangerously close to the muscle. So a 15-degree angle is a total miss for this specific procedure.
Okay, so what about the other extreme? What if they just go straight down at 90 degrees?
At 90 degrees, the needle punches straight through the mucosa, straight through the submucosa, and buries itself directly into the muscle layer.
And injecting fluid there does nothing to lift the tumor.
Right. It offers absolutely no protective cushion for the cutting phase. So the sweet spot, the absolute requirement here, is a strict 30 to 45-degree angle.
Got it. So the 45-degree trajectory ensures the needle actually bypasses that superficial lamina propria entirely.
Yes, it bypasses it, but stops just short of the muscle, landing perfectly in the submucosal space to achieve that essential, swift elevation of the lesion.
Wow. Visualizing a surgeon trying to hold a perfectly steady 45-degree angle through a flexible tube while a patient is, actively breathing and their digestive tract is moving, it sounds impossible.
Well, it's incredibly difficult.
How do they keep the needle from just slicing the tissue open every time the patient takes a breath? The manual kind of makes it sound like drafting on a static blueprint, but this is a highly dynamic environment.
That dynamic movement is actually a critical part of the technique. The fluid isn't just a static barrier, it is a tool. Once the needle tip is anchored correctly in that newly formed cushion, the doctor physically uses the catheter to push and pull the tissue.
Oh, so they move with it.
Yeah, they're actively manipulating the wall of the colon to expose the most inaccessible, hidden parts of the lesion, moving with the patient's breathing rather than fighting against it.
And they also have a very specific directional strategy for building this fluid cushion. They start injecting from the anal part of the lesion, the side furthest away from the camera, and then they move toward the proximal part, the side closest to them.
Building the cushion from the back to the front is really the only way a doctor can maintain spatial awareness in such a confined space.
Because if you build the front first, you blind yourself.
Exactly. If you lift the part of the tumor closest to the camera first, you create a physical hill of fluid that entirely blocks your line of sight to the rest of the tumor. It's a masterful application of 3D geometry and foresight.
Okay, so in the GI tract, fluid is your best friend. You use it to build hills and create safe zones. But what happens when you move to a part of the body where you can't just inject a massive fluid cushion? Up in the throat and the mouth, the rules of this geometry seem to change completely.
They do, radically.
Let's talk about the throat first, specifically percutaneous injection laryngoplasty.
Right, so this is a procedure utilized to inject material directly into the vocal folds, typically to treat paralysis or severe weakness of the voice.
And the entry point for this is on the outside of the neck. And the clinical guides specifically note that the doctor must ascertain the anatomical landmarks using a gloveless hand.
I love this detail because it highlights a profound moment of contrast in medicine. We spend so much time discussing rigid coordinates, yet the initial targeting mechanism for the human voice box relies entirely on the nuanced, tactile feedback of bare human skin.
It's amazing.
The doctor needs to palpate, to actively feel the exact borders of the thyroid cartilage, the cricoid cartilage, and the cricothyroid membrane.
So they're finding a tiny window between those rigid structures. They insert the needle almost perpendicularly right under the border of the thyroid cartilage. But they aren't relying on a camera here, right? They rely on the physical feeling of the needle slipping underneath the cartilage to know they are heading toward the paraglottic space.
Right, and the paraglottic space is essentially a narrow corridor of connective tissue that flanks the vocal cords. It's the anatomical highway they need to travel. But human anatomy in the larynx actually prevents a straight line of sight, or even a straight path of entry, to the vocal folds themselves.
Which brings us back to that visceral hook we started with. Once the needle is partially inside the patient's neck, the doctor literally pushes the syringe against the outside of the neck skin to forcefully bend the needle at the hub to a 30-degree angle.
It's wild. In some specific techniques, they even create two 45-degree bends in the needle before inserting it, forming a 90-degree hook, allowing them to drop topical lidocaine directly down onto the vocal folds from above.
It's like putting a straight key halfway into a lock, realizing the mechanism is around a corner, and bending the key while it's still inside to make it work.
That is a great way to picture it.
And the target they are trying to reach with this modified tool is incredibly complex. They are actually aiming for the lamina propria of the vocal fold. Earlier, we talked about how a 15-degree angle hits the lamina propria in the gut, which causes a leak, but here in the throat, it's the main target.
It is, because the vocal folds are not simple flaps of skin. They are highly specialized instruments, and their lamina propria is built in distinct layers.
Wait, layers within that tiny fold?
Yeah, the superficial layer is loosely organized, acting almost like a gelatinous shock absorber, but beneath that, the intermediate layer is densely packed with elastin fibers, and the deep layer is heavy with collagen fibers.
And the sources mention that these elastin and collagen fibers are oriented longitudinally, meaning they run lengthwise along the cord. Why is that specific orientation so important?
Because human vocal cords vibrate hundreds of times per second when you speak or sing. The intrinsic laryngeal muscles exert immense mechanical stress on the tissue.
So they need reinforcement.
Exactly. Those longitudinal elastin and collagen fibers act like biological guitar strings or reinforced steel cables, specifically aligned to withstand that rapid-fire tension without snapping.
So a surgeon is navigating a manually bent needle purely by tactile feel but unlike the soft tissue navigation in the stomach or the neck, where doctors use 30 or 45-degree angles to glide between layers, these dental inserts demand brutal, unforgiving precision. The holes drilled into the denture acrylic and the corresponding sites prepared in the gum tissue must be at absolute right angles. 90 degrees, no exceptions.
The tolerance for error here is practically zero. In the GI tract, fluid can forgive a slight miscalculation by spreading out. But here, you are dealing with a hard metal prosthetic interfacing with living tissue that's resting directly on bone.
Right.
If the titanium insert is placed too deeply into the tissue, it simply fails to develop any retentive grip. The denture will just fall out when the patient tries to speak or chew.
And if the dentist miscalculates the depth and places the insert too shallow?
Well, if it is too shallow, the base of the metal mushroom protrudes. When the patient bites down, that protruding metal drives into the surrounding mucosa, causing severe ischemia.
Ischemia being a restriction of blood supply.
Correct. The physical pressure of the misaligned insert pinches off the local blood vessels. Without a constant supply of oxygenated blood, the surrounding tissue experiences chronic inflammation, eventually leading to tissue death and the complete loss of that receptor site.
Adding to the pressure, the surgeon has to map out these 14 perfect 90-degree spots while actively avoiding major anatomical landmines. The manual specifically emphasizes avoiding the greater palatine nerves and the low-dipping antra.
Yeah, the greater palatine nerves are major sensory bundles that supply feeling to the roof of the mouth. Hitting one with a titanium insert would cause excruciating nerve pain.
And the antra?
The antra refers to the maxillary sinus cavities located just above the upper jaw. In some patients, these sinus floors dip very low. A miscalculated depth could result in drilling a prosthetic pin straight through the bone and into the nasal cavity.
Yikes. The contrast is just incredible. In the soft, squishy world of the stomach, 45-degree angles are used to gently slide between cellular layers. But against the rigid, hard palate of the mouth, it requires 90 degrees of absolute perfection, or the tissue literally suffocates itself against the metal.
This illustrates perfectly how the geometry of an injection or an insertion is entirely dictated by the biomechanical properties of the target tissue,
Yeah.
which actually brings us to the biomechanical studies in our sources.
Yes.
They reveal a reality that often goes unmentioned in surgical manuals.
Mm.
The tissue is not a passive recipient.
This was honestly the most mind-blowing part of the reading for me. When a doctor injects fluid at these precise X, Y, and Z coordinates, the human body pushes back. It pushes back physically with measurable force, and it pushes back on a microscopic cellular level. Let's look at the physical resistance first. There was a fascinating biomechanical study using minipigs to measure the exact physical force required during subcutaneous injections.
Right, the researchers utilized dextrin solutions, which is a complex carbohydrate fluid mixed to varying thicknesses or viscosities. They discovered that the tissue actively contributes a measurable back pressure.
So it's fighting the fluid.
Exactly. The resistance a doctor feels on the plunger of a syringe is not just the mechanical friction of the fluid moving through the needle shaft. The tissue itself physically resists the intrusion of the new volume.
And the study measured this back pressure in newtons. They found that the resistance increases linearly based on how thick the fluid is and how fast the doctor pushes the plunger. For context, they tested a thin fluid, about 1 millipascal second, which is essentially the thickness of everyday water.
And how much force was that?
Injecting that generated about 1 newton of resistance force from the tissue. But when they used a thicker fluid, like 20 millipascal seconds, which would feel somewhat like a thick cough syrup, and pushed it in fast, the tissue fought back with almost 13 newtons of force.
13 newtons is a significant amount of localized pressure.
Just to ground that number for you listening, 13 newtons is roughly equivalent to balancing 3 pounds of weight on the tiny surface area of a syringe plunger. It requires serious thumb strength. It's like trying to quickly pump air into a highly pressurized bicycle tire. The faster you pump and the thicker the air, the harder the tire fights to push the pump handle back at you.
And what's wild is that the researchers also uncovered a highly dynamic variable during the procedure: the temperature of the fluid.
Oh, right.
The fluid sample actually warms up while sitting inside the metal needle within the patient's tissue. This slight increase in temperature lowers the viscosity of the fluid mid-injection, which in turn alters the resistance force in real time.
So the geometry and physics of the injection are literally changing by the second based on the body heat of the patient?
Exactly. Every injection is a profound mechanical disruption. You have the Newton forces of fluid violently wedging tissue layers apart. But the sources detail how the body responds to this disruption, not just with physical force, but with a complex biological alarm system.
And this transition from macroscopic physics to microscopic biology was captured in a study observing rat pup bladders. The researchers focused on the cells within the lamina propria network. They found that when these cells are mechanically stimulated or disrupted by an intrusion, they don't just sit there. They communicate with one another using rhythmic calcium events.
Yeah, and what exactly is a calcium event in this context?
Well, according to the study, it is a sudden, rapid influx of calcium ions into the cell. It acts as an electrochemical signal, essentially flipping a switch inside the cell that tells it to react to a stimulus.
And the researchers didn't just note that the cells were signaling, right? They measured the geometry of the communication.
Right. They looked at the temporal order, meaning which specific cell fires its calcium signal first, the exact physical distance between the firing cells, and most crucially, the angle between the signaling sites.
Because measuring the angle of the signal propagation is how they determine if the tissue is panicking or organizing.
Panicking versus organizing.
Yeah, if the cells are firing randomly, the data will show an equal representation of all angles, basically a 360-degree spread of chaotic noise. But if the researchers identify a high bias in a specific angle, meaning a vast majority of the cells are passing the calcium signal along the exact same directional path, it indicates a highly coordinated, well-formed wavefront of cellular communication.
Man, it is exactly like a stadium wave at a massive sporting event. If the crowd is just randomly standing up and cheering at different times, it's just chaotic noise. You can't predict what's happening. But if you look at the geometry of the crowd and you see the motion sweeping at a specific angle across the sections, you know the crowd is highly coordinated and responding to a singular event.
It's a great visual.
The cells in our tissue are executing a microscopic, geometric stadium wave of calcium to communicate about the foreign needle entering their environment.
The synthesis of the macro and the micro here is stunning. In the same moment, A doctor is calculating a strict 45-degree angle of insertion to avoid a patient's colon muscle. They're physically fighting a 13-Newton back pressure from the tissue itself, while on a microscopic level, the cells are firing off their own geometric wavefronts of calcium to signal the invasion across the cellular network.
It turns a millimeter of human skin into a 3D battlefield of physics, anatomy, and cellular biology. And it completely rewrites the narrative that a medical injection is a simple, one-dimensional event.
Standard medical procedures that we take entirely for granted are actually quiet triumphs of applied spatial geometry and fluid dynamics.
So the next time you find yourself at the dentist getting a local anesthetic or having a procedure done, you are going to view that syringe very differently. You can picture the exact X, Y, and Z coordinates. You can visualize the doctor calculating that perfect 45-degree angle to slip into the submucosa, or that unforgiving 90-degree angle to anchor a prosthetic, and you can know that your tissues are actively pushing back, your cells lighting up in perfectly angled, coordinated waves.
Understanding those mechanics raises a really fascinating question about the future of medicine.
Oh.
We have established that tissue back pressure changes dynamically based on viscosity and temperature, and that cells communicate via highly directional, measurable wavefronts.
Right.
So what happens when we develop smart needles that can actually read this data?
Wait, a needle that actually listens to the tissue?
Exactly. Could a future injection device read the physical tissue resistance and the cellular calcium wavefronts in real time? Imagine a device that autonomously adjusts its own micro angles and depth shifting from 40 degrees to 45 degrees instantly based on cellular feedback to perfectly navigate into the lamina propria or submucosa without a single wasted drop of fluid.
Wow.
We're looking toward a future where a human hand may never have to manually bend a needle against a patient's neck again, because the tool itself understands the 3D topography better than we do.
It takes the guesswork out of the geometry. That's an incredible thought to end on. We started this deep dive thinking about a medical injection as just a simple shot, but it turns out there is no such thing as a simple shot. It is a calculated, dynamic journey through the most complex terrain on Earth. Thanks for exploring the hidden geometry of the human body with us today.